In today's podcast, we're going to talk about menopause management and to try and do that as simply as possible for everyone working in primary care. So these are the British Menopause Society recommendations, and the key message from this slide is that care should be individualised, and that can make it quite difficult to give clear recommendations. I have attempted to do that by developing some colour-coded, relatively simple pathways which you will be able to see on the platform. So women should not have the length of time that they use HRT restricted. Ongoing use will be based on an ongoing individualised risk assessment, and my practice is to review women annually, really to make sure that they have had a chance to update their history, their blood pressure should be checked, and I think it's also important to consider whether their weight is stable. Women who have premature ovarian insufficiency are in a group of their own. So whilst NICE has been very clear that women over the age of 45 do not need a blood test, do not need their FSH level checked before they go on HRT, women who are under the age of 40 should have two separate FSH levels, ideally approximately 6 weeks apart. And in an ideal world, these women will be put onto a register because they will often benefit from care by a multidisciplinary team. So those really, I think, are the two important messages. Care should be individualised, and there really is no place for measuring FSH in women who are over 45 who are symptomatic of the menopause. I think it's very confusing for patients and for healthcare clinicians alike because there is so much conflicting information around. This is a menopause booklet which was written for patients, but it's fairly high level, and actually I think it gives a really good basic understanding for everyone in primary care, whether that be a GP, practice nurse or a pharmacist, and that's available at a minimal charge from Carger on their website. So what I'm going to talk about in this morning's podcast is the physiology and definitions, how to make a diagnosis, and going back to what I said before, this is about listening to the patient. And then we're going to talk about managing menopausal symptoms with a focus on menopausal hormone therapy, which is the favoured term now rather than HRT. And the reason for that was that HRT was very much tarred with the WHI brush from 2002 when an awful lot of damage was done and many women came off HRT. And we know even now that although a significant number of women are suffering from menopausal symptoms, only around about 10% are being treated with hormones. And of course there are other ways of treating menopausal symptoms, but I go back to the fact that this is a deficiency state, and the logical thing to do is to replace what women are deficient in, i.e. estrogen, with or without a progestogen. I seem to be stuck. Okay, let me just make sure we've not missed anything. Which we have. Okay, so postmenopause is easy. That's 12 months after a woman's last menstrual period. What's much more difficult to quantify is the perimenopause or the menopause transition, because this can go on for a very long time. We know that a significant number of women still suffer from menopausal flushes 7 years after their last menstrual period, and these can go on for longer than that in a small number of women. So the menopause transition starts often long before a woman's last menstrual period. It is characterised by variation in hormone levels. So you have FSH from the pituitary desperately trying to make the ovary ovulate. That doesn't very often happen as women get older, but they can have variable levels of estrogen because the developing follicles will produce estrogen. And these levels essentially can be all over the place, which is what's really difficult to cope with. But if you think about it, estrogen is going to make the lining of the womb proliferate, so it gets thicker. But because women don't ovulate, they don't produce progesterone, the naturally occurring hormone, which is released by the corpus luteum. And so what we have is unopposed estrogen, which will often cause the lining of the womb to thicken and shed chaotically, which is why heavy menstrual bleeding is a common symptom in the perimenopause, along with all of those other classic symptoms like hot flushes, night sweats, and things that we talk about less often, like anxiety, loss of confidence, difficulty concentrating, memory issues, all of which can make it very difficult for women to function in the workplace. That's the register that I talked about before for women with POI. And I'm not going to keep pressing this because I think that is going to cause a problem. I'm sure that this slide will change eventually. Okay, so these are, well, this is a summary of those common menopausal symptoms. We've talked about some of them already. I think low mood can be treated with antidepressants, but that is not the first line way of managing that symptom in menopausal women, as it will more often respond to hormone therapy as long as the individual doesn't have a reason why hormone therapy should be avoided. For example, women with estrogen receptor positive breast cancer. Musculoskeletal pain is also a very common menopausal problem, and the variety of symptoms with which women present is so diverse that really actually they could be referred to lots of different places. It could be psychiatry, it could be rheumatology. And, you know, I think such good care can be provided in primary care with clear guidelines, which is what I'm hoping to do today. So often women will find when they take HRT, for example, that their classic hot flushes go, but that their sex drive and their drive generally doesn't improve. Testosterone is a very important female hormone. Female ovaries produce more testosterone than estrogen, but they do so less efficiently from about the age of 20 onwards. And lots of women will suffer from low libido, which impacts on their relationship and their general well-being. So that's important to remember. And then my personal interest is in urogenital atrophy. And about 80% of women will experience urogenital symptoms, but because these often start 3 to 5 years after the menopause, the association is not always there, and women don't always realise that lack of estrogen is affecting their urogenital tissues, the lining of the vagina, but also of the bladder, and therefore they don't think about hormone therapy to manage the problem. So I think, again, in primary care there is so much that can be done, particularly in relation to urogenital health before the problem occurs, when women attend for smears. So you have two ears and one mouth, and just let women tell you what the problem is. Listen, that's actually often all they really want you to do. I see an awful lot of women who have come describing a range of menopausal symptoms, who then inappropriately have an FSH level done. And when you think back to what I said about the menopause transition, if you do an FSH level at one point in time, then it may be normal, but it doesn't mean that that patient isn't suffering from symptoms associated with the menopause transition. And we know that treating women at the time of the transition results in the best cardiovascular protection, the best way of minimizing a reduction in bone mineral density, and both of those things are important long-term consequences of lack of estrogen. So listening is number one. There are very few things which need to be done as far as examination is concerned. A blood pressure and a body mass index, I think, are useful for a holistic consultation. If you've got somebody in the menopause transition with heavy menstrual bleeding, then a full blood count has a really important place. It may be appropriate to do ultrasound. And the NICE guideline in relation to heavy menstrual bleeding talks about using the most appropriate investigation, whether that's ultrasound or endometrial or hysteroscopy. But endometrial sampling should not be done blindly, so that would be done in association with hysteroscopy, which ideally will be done in an outpatient setting. Hysterosonography is introducing a fluid like saline into the endometrial cavity and using that to enhance ultrasound. And actually, the NICE guideline doesn't recommend that, but I use it frequently and find it very useful. So treatment to manage specific symptoms. So vasomotor symptoms are best managed by hormones as long as there is no contraindication. There are non-hormonal treatments available for women who do have contraindications. And actually, my clinical experience with those is that they're not particularly effective. So we're talking about drugs like antidepressants, which can impact on flushes. Things like venlafaxine and mirtazapine would be my preference. Clonidine is licensed to manage hot flushes and, in my opinion, is not a very effective treatment. But if you get the dose up, it will work for some women. Women who have estrogen receptor positive breast cancer may be eligible for treatment with Megace, which is a progestogen. There is anecdotal evidence to suggest actually that low dose oxybutynin, 5 milligrams a day, can be successful at treating flushes. Gabapentin in high dose, 900 milligrams a day, can be useful. So those are all useful to understand for those women who can't have hormones. They are not appropriate first-line treatment for women with no contraindications to HRT. With altered sexual function, the idea is that you replace the deficient hormones, i.e. estrogen, plus a progestogen for women with an intact uterus, or women who've had a subtotal hysterectomy potentially, or women with a history of endometriosis, and then testosterone is added. So if we're going to provide testosterone, there are no licensed products for women. We use male products out of product license, which is not uncommon. Personally, I don't do blood tests beforehand because it won't influence my care of the patient, but if women fail to respond to testosterone, then I would check a testosterone level and a sex hormone binding globulin level. So if we're going to give estrogen to patients who potentially might need testosterone, then they should have that transdermally, because transdermal delivery doesn't increase sex hormone binding globulin, which is just like a big sponge and will mop up any pre-existing testosterone, and also your exogenous treatment should you choose to prescribe that. Low mood can also be managed by cognitive behavioural therapy. That's an option, particularly for women who can't have HRT. And that can help with low mood, as can antidepressants that you might be using for flushes in women who are not eligible for HRT. There are some newer treatments which hopefully will come to market. One is estetrol, that's fetal estrogen, which is thought to be safer from a breast perspective and also from a DVT risk perspective. And then urogenital atrophy is an area where we're seeing many new products now, whether those be new vaginal estrogens like Invagis, which is estriol, and also Blissol, which is a gel, and it's also estriol, which is a weaker estrogen and has less impact, although I think it's important to be clear that vaginal delivery results in minimal systemic absorption, particularly once the treatment has had a beneficial effect, because a very thin vaginal mucosa will cause a little bit of estrogen to be absorbed systemically, not significantly though. You can add vaginal estrogens to systemic HRT, that's absolutely fine. And of the newer treatment options, in addition to Invagis and Blissol, we have ospemifene, which is a SERM, 60 milligrams daily orally, so very good for women who are not on HRT and who do not want to apply something directly to the vagina or the vulva. Prasterone is DHEA, dehydroepiandrosterone, and that is converted in the vaginal mucosa in a process known as intracrinology into estrogen and also testosterone, which we know has a very profound effect on the connective tissue in the urogenital area. And then laser therapy, which is a very new treatment area, only available in the private sector, but a non-hormonal way of managing urogenital atrophy. We'll talk about that a little bit later on in the next podcast on urogenital atrophy. So in simplistic terms, the problem, as I said before, in the menopause is estrogen deficiency. And so what you want to do, ideally in a woman who has no contraindications, is to replace what she's deficient in to manage both short-term symptoms like hot flushes and night sweats, which may be impacting on quality of life and productivity in the workplace, and also to minimize long-term consequences of estrogen deficiency, which include an increase in the risk of osteoporosis and an increase in cardiovascular risk. Okay, just waiting for that slide to change, which gives you a little bit of a chance just to catch up. So if a woman has no uterus, it's very easy. She only needs estrogen. If she does have a uterus, then she's going to need a progestogen to reduce the risk of the lining of the womb becoming too thick, hyperplasia, which is a risk factor for cancer. So we would normally recommend that a woman had been at least 12 months since her last menstrual period if she was going to commence continuous combined HRT. That's both hormones all of the time. If the patient presents and she's still having periods, then we would normally administer the progestogen in a cyclical manner to induce a withdrawal bleed when she discontinues the progestogen, and that's to reduce the risk of chaotic bleeding. To get around all of this, we can use Mirena for all three of its licensed indications: for heavy menstrual bleeding, to reduce bleeding, for contraception, which is required until the age of 55, and as the progestogenic arm of HRT. And Mirena, out of all of the intrauterine systems, and there are 4, is the only intrauterine system which has the license for endometrial protection. And it would be bad practice to use something out of product license where a licensed product existed. So how do we give the estrogen? Orally, through the skin, transdermally, by implant, or vaginally. There are no products in this country which provide systemic levels of estrogen when the product is delivered vaginally, and all of our estrogen for vaginal delivery is to manage urogenital atrophy. Lenzetto is a new transdermal estrogen. It's a spray, and it delivers 1.5 milligrams of 1.5 micrograms of estradiol through the skin. So when you think about estrogel, 2 pumps of estrogel will provide 1.5 milligrams, get my milligrams and micrograms mixed up, of estradiol. Sandrina, which is another gel, comes in 2 strengths, 1 milligram and 0.5 milligrams. So Lenzetto is providing, in a very simple way, it's a spray which is applied to the palmar aspect of the forearm, rapidly absorbed, gives a reasonable strength, and younger women will often require higher levels. Where Lenzetto might, I suppose, be limited is in the older women, because the recommendation is that we use the lowest dose, which controls symptoms. So over 60, it would be unusual to use 1.5 milligrams of estradiol. For many areas, Lenzetto will have to go through drug and therapeutics committees, although it is a licensed product. So I'm just going to talk about risks now. So what patients worry about is the risk of breast cancer. The risk of breast cancer for all women is about 1 in 7 lifelong. So the risk is very high. Inevitably, there will be women on HRT who develop breast cancer. And what's important is that those women are no more likely to die of breast cancer than the women who didn't have HRT, but they might present sooner because the lump will be influenced by the hormones, and therefore their outcome is influenced by the speed with which they're dealt with. And this has to be balanced against the other benefits of HRT. So myocardial infarction is the commonest cause of death in women post-menopause, not breast cancer. And by providing HRT early on, the risk of cardiovascular disease will be reduced. And therefore, this is all about balancing benefits against risks. Obviously, if a woman has a very strong family history of breast cancer, that's relevant, but it doesn't mean that she can't have HRT. And there's some evidence now that even women with breast cancer, particularly those treated with tamoxifen, in extreme circumstances may be eligible for treatment with HRT. In addition to estetrol, one of the other new products which I didn't mention before are NK1 and 3 inhibitors, which reduce flushes, and those are non-hormonal treatments for flushes, which, I think there's a lot of hope that these will become a product which is licensed particularly for women who have really good reasons to avoid hormone therapy. I don't want to keep pressing this in case we go through several slides at a time. So cardiovascular disease, if somebody goes through the menopause and does their best to avoid hormone therapy because they believe that to be the best thing to do, if it's 10 years before they think that they can't cope without HRT, then there will be no cardiovascular benefits. So the longer women are left without estrogen, the more likely they are to build up atheroma. Now, obviously, that's not something that should be looked at in isolation. It's really important to consider, does she smoke? Does she have a family history of high cholesterol, of cardiovascular disease? But we do know that estrogen is cardioprotective and it's best started earlier rather than later. Because once there's a significant amount of atheroma, that can become destabilized by estrogen. And we also know that transdermal estrogen is much safer. It doesn't impact on DVT risk, and it has much less impact on the risk of stroke. So when you consider that you're much less likely to cause harm with a transdermal preparation, I think it becomes more difficult to justify why you would use oral therapy unless the patient had no contraindications and was very keen for that. And there's a familiarity with taking things orally. But we do know that women who have oral medication may actually ultimately receive about 10 to 40% of what they swallow. And women who've had weight reduction surgery, depending on what that is, may not absorb oral therapy. So that's worth bearing in mind. So with cardiovascular treatment reduction, cardiovascular risk reduction in association with treatment of the menopause, there is something called the window of opportunity. And that's anything between 6 and 10 years post-menopause. You can still provide that patient with a cardiovascular benefit. So if we think now in very simple terms about how to design a suitable regime, choose your estrogen. How are you going to give it orally, transdermally? Will that be a gel? Will it be a spray? Will it be a patch? And then add in a progestogen. So if it's an oral treatment, you may be looking at commercial preparations. My personal preference, the way in which I deliver care would be normally to use a transdermal estrogen, and with progestogen to use either Mirena, or many patients don't want Mirena because it's uncomfortable to be fitted. I mean, that's the honest truth. And some women can't tolerate the progestogen, levonorgestrel, but there is now the option to add in micronized progesterone, utrogestan. 100 milligrams every night is mildly sedating. It reduces anxiety. Women sleep better. But again, you get some women who are unable to tolerate progestogens, and therefore that also allows you to minimize the amount. So if we go with what would be acceptable, the minimal amount of progestogen would be, in my opinion, 10 days of utrogestan every 70 days. And there are commercial preparations like Tridestra, which have similar amounts of hormones. But you have to remember that the less progestogen you provide, the less endometrial protection you provide. Then androgens, as I said before, we use male products, either Testagel or Tostran, women apply. about a baked bean size daily. Usually that's more physiological. And I would only suggest measuring bloods if she's not responding as you expect. And what you want really is the free androgen index, which can be calculated by measuring testosterone, multiplying by 100 and dividing by sex hormone binding globulin. Remember to ask every patient if she has vaginal dryness, does she have pain during sex? Because not many women are going to volunteer that unless they feel confident that the information will be managed appropriately, and it's much easier if you just ask. And we've covered some of the newer treatments which are in the pipeline. So I hope that was interesting. I hope you find the pathways useful, and you can post any questions at the paulabriggspodcast@gmail.com. Thanks for listening to today's podcast. I hope you found it useful. I hope that the information was easy to take on board, and I hope you'll join us next week for a very important podcast about urogenital atrophy, a common condition, as I said today, affecting up to 80% of women.